Very good morning. Are my slides visible? Am I audible enough?
Yes, yes.
Go ahead.
Very good morning, respected panelists. With pleasure, I take you through this interesting study entitled "Can rate of retinal vascular growth be a predictor for treatment in babies with retinopathy of prematurity?" Retinopathy of prematurity is a disorder of immature retinal vasculature. Various systemic factors modulate the disease severity and incidence via a common endpoint of retinal vascular stasis or decelerated vascular outgrowth. This led us to analyze the rate of retinal vascular growth per week in treatment-naive eyes with retinopathy of prematurity and to evaluate whether it could be a predictor of treatment need. This was a 10-year study, partly retrospective and partly prospective, from 1st January 2010 till 2019 at LV Prasad Eye Institute, Bhubaneswar. We included babies cared for retinopathy of prematurity with clear fundus showing the disc and vascular endings in one imaging field. Those with incomplete details, stage 4 and 5 and no consent were excluded. We used RETCAM shuttle and Trinetra Neo for calculation of the speeds. Two retina specialists masked to the post-menstrual age and treatment need did all the evaluations, while a third examiner cross-checked. The inbuilt caliper system available with RETCAM shuttle was used for calculation, while in Forus we used measuring scale manually for the calculations. The image enhancement was done with red-green software to make the blood vessels stand out. The horizontal disc diameter was taken as the unit of measurement. So the speed was calculated as S is equal to A by D divided by P minus 17, where A is the distance of the end of the blood vessels from the midpoint of the temporal or nasal optic disc margin, and D is the horizontal disc diameter, P is the post-menstrual age examination. Based on the previously published report, we assume that the blood vessels reach the optic disc margin at 17 weeks of gestational age. These are the statistics we used. We compared the speed between the different groups. We also assessed the reproducibility of the result by using interclass correlation coefficient among the observers. The ROC curve was used to assess the predictive value of the speed and deciding the treatment need. There were 436 eyes from 233 babies classified into group 1, treatment requiring ROP, group 2, ROP spontaneous regression, group 3, prematurity but no ROP. This acted as control. The group 1 was further subdivided. The rate of retinal vascular growth in disc diameter per week was lowest in treatment warranting group, followed by spontaneous regression, followed by no ROP, where it was 0.71. The subgroup analysis showed the rate to be the lowest with aggressive posterior retinopathy of prematurity, followed by threshold, hybrid, and high-risk pre-threshold. We measured all the quadrants wherever feasible, but the examiners had a tendency to calculate the superotemporal and inferotemporal quadrant more often. The speed in the nasal quadrant was more than 50% less than the temporal quadrant. And when we calculated the speed versus the treatment need, irrespective of the group, we found that when the speed is less than 0.4, 99% is required treatment. The receiver operating characteristics showed that rate of vascular growth could be a significant predictor of treatment need, and the cutoff value set was 0.56 for superotemporal, 0.57 inferotemporal, 0.5 for horizontal temporal, with the following accuracy. The major limitations was the measurement in a flat laptop screen, where in reality, the blood vessels traverse a curved ocular surface. Lack of FFM, we compensated this by using the red-green enhancement to make the blood vessels stand out. The rate of vascular growth is not uniform. We assumed it to uniform between the 2 points of time, but actually they change from day to day. The rate different in different quadrant, we addressed it by calculating the average as well as comparing each quadrant. Issues of reproducibility, we ensured it by using inter-observer correlation coefficient and used 2 observers. Errors due to image magnification was addressed by using the ratio as the measurement unit rather than the absolute value. To conclude, retinal vascular growth, the rate of retinal vascular growth could be quantifiable and could predict the treatment need with many extrapolative use that can be used for us. The rate is inversely proportional to the disease severity, lowest in aggressive posterior retinopathy of primitive and slowest in the horizontal nasal quadrant. At a retinal vascular outgrowth less than 0.5 for disc diameter per week, there is a high probability of treatment need. I acknowledge all of them for their support, either direct or indirect, and thank you all for your kind attention.
So, impressive study, truly, Tapas, great attempt. I just want to know, it didn't come out very clearly. You used the Retinam shuttle and the Trinetra to image. So for all these, were they standardized to one imaging modality, or was it a mix of two? Because
So
it's the magnification which matters here. So, because you're calculating, like I correctly said, a curved surface, but you're looking at it on an imaging flat screen. So that factor becomes very important when you make,
yeah, very true. This is the reason why I use the ratio. So whatever we measure the distance of the end of the blood vessels from the optic disc margin with respect to the horizontal optic disc diameter. So like shown here. So we use the ratio. So even if the image gets magnified, the ratio remains same. The ratio, that is the A by D divided per week. That is retinal vascular outgrowth per week.
All right.
That's a very nice presentation.
Thank you, ma'am.
Yeah, could you look at any changes that varied with the stage of the disease? You looked at the quadrants. But if you look at any
Ma'am, can you repeat?
Your volume is a little less, Dr. Muna. You're not hearing you at all now.
She said, does it vary with the state of the disease and not just the quadrants which she mentioned?
Yes, yes, ma'am, it varied. So if we see that we, to help us in real life situation, we did the measurement in terms of the threshold ROP versus FP-ROP and high risk pre-threshold ROP. So in threshold ROP, we saw that the speed was the second lowest compared to the FP-ROP. So whereas in high risk pre-threshold and in no ROP group where there was no disease at all, the rate was maximum.
Thank you.